as you know, Mercy Medical Group and Dignity's had a telestroke program for about the last 7 years. They are not only in the 4 Dignity hospitals in this market, but they're in 32 hospitals in California, from Shasta all the way down to Oxnard, Santa Cruz, a lot of the smaller hospitals along the Sierra. We have 10 neurologists that man that 24/7, and we have in-touch robots in all of the EDs. They're all programmed actually to go to the scanner or go to the ICU automatically now, so that they're fairly sophisticated. You can run it through the iPad, through laptop, desktop, doesn't matter. So the platform it's really web-based and very effective. So within 5 minutes, the ED doc can be on with one of our stroke neurologists and doing this exact thing. And we're finding 15 to 18% of the patients need to be transferred because they have large vessel occlusion as well. So they don't all have to come to us. We do have 2 places at Mercy General and Mercy San Juan that both can do the endovascular work. But if you're in Oxnard, you don't want to be transferred to Sacramento. So we have relationships with Stanford and UCLA and a variety of other places that can do the endovascular work because that's the right thing to do for the patient. So Dr. Schatzel, this was his brainchild, and he's spoken here before, said that with what they've done, if you were to really man those hospitals with a couple of stroke neurologists, they're doing the equivalent work of 60 FTE neurologists on this project with 10 people. So, and it's fast. It's really fast. And they do the same thing. You have to go through training. The stroke codes have to be run in the same way for each hospital so that it actually, you can do these things in a very timely way and have very short door-to-needle times. So you don't have to go to Kaiser if you have a stroke. I wouldn't mind going there now. But as I said, we see Kaiser patients too because they end up in our emergency rooms, and that's great. But the better we're able to do this as a community of providers, the better off everybody is. So it's great stuff. This is really advanced stuff, and then putting it in place that quickly, that is incredibly impressive. That's really good stuff. So, with no further ado, I'd like to introduce Elizabeth Malcolm, who is the Director of Implementation and Evaluation for the Clinical Excellence Research Center. Now, I thought she worked for CERN and the Large Hadron Collider. It's not exactly the same thing, but it's a health services research, clinical excellence research center, so they implement ideas of how to provide excellent care. She graduated from New York Medical College. She was a Robert Wood Johnson Clinical Scholar at UCLA. I don't know if you know Marty Shapiro. He was my mentor when I was an intern and resident there. She also got her master's in health services research from UCLA. And she worked for the Gordon and Betty Moore Foundation. You'll have to tell us about that a little bit. That's very interesting. And she also worked for a large system and also for RAND. So please join me in welcoming Elizabeth Malcolm.
Thank you so much for having me today. Hattie, I want to thank you very much for inviting me. I know Hattie's had Arnie here a couple times, so I'm trying not to repeat things that Arnie has already taught you. I'm going to be talking today about some work that we're doing at CERN that really is at the very beginning stages, and Hattie and the Right Care Initiative has been an incredible supporter for us, and we're really looking forward to collaborating to create, to have California be, world-class, high-value stroke state. So let's go ahead and, how do I do this here? Sorry, Carla has walked out of the room, so. Okay, so today we're going to first talk about the Clinical Excellence Research Center. I'll tell you a little bit about the work that we do, and we'll talk about better stroke outcomes with less spending. And then we'll spend the bulk of the talk on closing the knowledge to action gap for stroke. And then finally, we'll talk about a project that we're trying to get going in California which is the California Door to Needle Challenge. And then I'd love your feedback and thoughts about this work. So CERC, the Clinical Excellence Research Center at Stamford, was founded about 5 years ago by the president of Stanford University, John Hennessy, who was looking at the biggest problems in America today and identified healthcare spending as a problem that Stanford needed to solve. So he brought in Dr. Arnie Milstein, our director, to create a center that's really focusing on improving the value of healthcare in America. And Arnie, many of you may know Arnie, but his primary focus is really lowering the cost of care. So we're not just interested in improving value by improving quality. Everything that we do at CERC also has to reduce costs. And one of the big components of our center is a fellowship program where we bring in fellows who are clinicians, engineers, and social scientists, and they're given a target in healthcare, and they're asked to create a model that will reduce healthcare spending by 50% for that condition, while simultaneously keeping quality the same or improving quality. And these fellows go through this process that includes sort of the human-centered design work that's done by the Biodesign Center at Stanford, and also looking across the globe at practices that are able to achieve the highest quality at the lowest cost. And generally what they come up with are these bundles of care. And Dr. Klingman was talking about the Helsinki bundle previously. So they come up with these bundles of care that, when taken together, can really move the needle for costs in healthcare in America. And what you're seeing, these three here on the bottom right-hand corner of the slide, are our high-value stroke care team.
So they first presented the Helsinki model in this room in May 2013. And that has started a wonderful, that was a great catalyst for some nice change, including having Jeff Klingman see the presentation at our summit that year. And he got so excited, he said, I'm going to do something about this. And he has. So your work really matters.
That's great. So these three fellows who are doing amazing things right now came up with a model that actually has three components. And it sounds like we've heard this before. But just quickly, the bundle includes first avoiding stroke and heart attacks by maximizing preventative medication use. Second, converting hospital care of transient ischemic attack and mild stroke care into safe alternative care settings. So moving care from higher cost settings to lower cost settings. And then finally, transforming stroke care, which is what we just talked about, making sure that we're enabling faster TPA treatment and improved transition to post-hospital care. And this model taken together is estimated to reduce an 11% net reduction in direct healthcare spending on stroke and heart attacks. And so just kind of the big picture here, so today I'm actually going to really be talking about the T component of this model, and I'm not going to spend time on the hospital piece so much on the hospital piece of faster TPA treatment, but I wanted to sort of talk about the big picture of what it would mean if California could achieve this national exemplar status on high-value stroke care. And essentially, the whole idea is that if we can achieve more patients getting TPA, get people in the door and treated within 4.5 hours of experiencing the onset of stroke symptoms, there would be a tremendous impact on healthcare spending because of fewer disabling strokes annually. So that's kind of the big picture of where we're headed to at CERC. And finally, if we're able to get it under 3 hours, we could see around 0.3 billion less healthcare spending nationally annually. So that's where we're headed. So when the stroke team looked at this system of stroke care, they look to see where the different leverage points in the process might be for getting a faster TPA treatment time, or acute stroke treatment time. And there are 3 upgrades that they've proposed. The first is a patient caregiver process upgrade. And that is the patients and caregivers actually recognizing the symptoms of stroke, attributing those symptoms to stroke, and calling 911. The second piece is the EMS process upgrade, which is a better coordination between EMS, better recognition of stroke, and better training for EMS, and then better coordination between EMS and hospitals. And then the third is this hospital process upgrade, which we just spent the last talk speaking about. So today we're going to talk about first this patient and caregiver response upgrade. And if you can see the chart on the left, you can see that the pre-hospital time attributed to decision delay is by far the largest delay in patients receiving treatment for acute stroke. But it's also the hardest thing to address. So transport time and time on scene are much smaller portions of this time. And as you can see, hospitals are really getting on the bandwagon to adopt these highly efficient care processes around delivering TPA. So the piece of the puzzle that hasn't been solved yet is the decision delay, the delay in the time from the onset of symptoms to a patient seeking emergency care. We all know that use of EMS is associated with early arrival, faster triage, and greater TPA use. And this was something, I'm not a stroke doctor, so it was something that I learned as I started to understand this project more. It's fascinating to understand that patients that drive into the emergency room actually end up having a much longer delay in receiving TPA than patients that arrive via ambulance. So until we can improve our ED, our walk-in systems of care a little bit faster, right now, use of EMS really needs to be the way that patients who are experiencing acute stroke get the most efficient care. And then finally, delays remain common. So this decision delay remains extremely common despite the fact that the public has, over the years, has gained more knowledge of stroke. So when I started to dig into this literature a little bit more, we went to look at, what kind of impacts have these mass media campaigns, and what kind of impacts does patient education have on reducing that decision delay for patients. And in general, what the literature says is that increased knowledge of stroke is actually not translating into increased inappropriate action. So patients may be able to tell you what the signs of stroke are, but when they actually experience a stroke, they do not consistently call 911. And that's even for patients who have been trained in the FAST model and in symptoms and what symptoms of stroke are. And also, when you look at these mass educational campaigns, you don't see, a lot of times they don't study. They study whether patients get knowledge, so they have patients taking tests, or they have they have consumers taking tests after they get the education, and the consumers are able to pass the tests, but they tend not to study the actual behavior of consumers at the time of stroke. So there's an interesting disconnect actually in research around whether or not mass educational campaigns actually do change patient behavior. So there have been lots of studies that look at factors that influence delay in either from the time of awareness of symptoms to seeking help, or the time of awareness to hospital arrival. And generally, the main thing that these studies show is that it's actually common sense. So if the symptoms are severe, then people tend to get to the hospital faster. Or if the symptom is perceived as severe. So, for example, if the person stops being able to speak or has, significant right-sided weakness. Another important factor is that others have advised you to seek help. So there are actually a lot of stroke awareness campaigns that focus on others, training others to recognize the symptoms of stroke and encourage people to call 911. And then there is some endogeneity here, but patients who contact EMS do get to the hospital faster. And patients who have a high perceived control of their symptoms, so they think that this is something I can take care of, those patients tend to delay. So there's so many different studies in so many different countries, and so the bottom right-hand corner of this chart, I don't think is replicable across all of our different communities. But in one study, being female and having a symptom that was not as clear-cut, like fatigue, tended to delay stroke very significantly. And obviously, stroke onset at night is another conundrum that people have around getting treated. So I think the take-home message from this is that when patients have ambiguous symptoms or mild symptoms, they tend to downplay those symptoms and delay calling 911.
Liz, in all of our discussions of stroke in the Right Care Initiative so far, which started in 2013, or more intensely since then, no one has ever mentioned fatigue as a symptom. Could you elaborate at all?
Well, I think that elaborate in that it is a symptom of stroke. I think that sometimes it's not a clear-cut, it's not a clear-cut stroke symptom, but when patients are having an acute stroke and they have less clear-cut symptoms like dizziness or, fatigue could happen as a result of, acute brain injury. So it's not, I wouldn't say it's a clear-cut, classic stroke symptom. My point here is that when patients have ambiguous symptoms that are associated with stroke, there's a longer delay. So lately, the AHA has pushed for us to really understand better why stroke patients and bystanders delay calling EMS. And if you break this problem down into its components, there are basically 3 components for why someone might delay. The first one has to do with recognizing the symptoms of stroke. So, for example, the different stroke campaigns do help people understand if they have, weakness on one side or slurred speech. They should know that those symptoms are associated with stroke. However, not just knowing that symptoms are associated with stroke doesn't actually mean that you attribute those symptoms to stroke. So back to this thing about if symptoms are a little milder and more ambiguous, people often downplay the symptoms. So say you have, your left arm is weak. Oftentimes patients who have been studied will say, oh, well, I slept on my arm funny last night, so that must be the issue. And so there's an important piece of the puzzle that has to do with interpreting the symptoms that you have and attributing those symptoms to stroke. Another important component of having patients attribute symptoms to stroke has to do with another person influencing you and raising raising your level of comfort with alerting the emergency system. And then there's a piece of this puzzle which has to do with negotiation. And so this is the part that I find very interesting, which has to do with emotional coping around experiencing something that is really scary. And so although we don't completely understand what influences people's behavior at the time of stroke, we do know that two issues have come into play in qualitative studies around this problem. One is the perception of medical services. So in communities where there's less trust of medical services or less trust of sort of the social system, people tend to delay calling because they don't trust that calling 911 is, or engaging the hospital is going to solve their problem. So when their symptoms are more ambiguous or they're milder, and there's low trust of medical services, there may be delay. And then finally, people want to maintain a sense of normality in the face of something that could be catastrophic. And so there's this emotional coping that happens around trying to maintain a sense of normality. So, you know, my arm's weak, I'm driving my daughter to work, I'm just gonna get my daughter to work and then I'll call 911. And then this does happen. And so that's kind of the setup for the first project that we're working on at Stamford right now, is really trying to develop an intervention that actually not just impacts people's knowledge of stroke, but their behavior at the time of stroke. So trying to close the knowledge to action gap. And so we are, with the help of and support of Genentech, are working on developing an intervention that focuses both on this recognition to interpretation piece, so helping people recognize symptoms, especially in milder cases of stroke, and attribute those symptoms to stroke. And then the second piece is addressing emotion-focused coping strategies and the perception of emergency and hospital services. So what we're planning on doing is using the literature of what we know right now and basing it on this logic model that we have. We will actually interview a series of patients who have experienced stroke and who have delayed calling 911 and engage them and in a user-centered design process to understand how we might develop a technology or a process to help patients better recognize and attribute symptoms to stroke. That process we're actually planning to start that in March, and we'll be developing this intervention over the next 3 to 4 months from March. And what we will try to do is use these theory-based strategies to close the knowledge to action gap. So it's very exciting. We're going to have, not only will we have our Stamford team, a stroke neurologist, an ED physician, and a pharmacist on the team, but we will also have a social psychologist who will be joining us to help us understand the human behavioral component of this, how this intervention should look. And then we'll be using patients in the design process. So we'll interview patients before to understand what kinds of technology or processes might they interact with when they're being trained to recognize and attribute symptoms to stroke. And then they will, stroke survivors and caregivers will participate in the design process for the technology. So that's really exciting in and of itself. The second piece is we're planning to partner with a pharmacy in Southern California. So we were talking before about what kinds of folks need to come together around this problem. And in a previous Right Care Summit, actually Ralph's Pharmacy contacted us and said they were interested in engaging with us around this problem, really for similar reasons as Hattie's. Rebecca Cupp, also husband, suffered from a stroke, and she's really interested in trying to address the issue of decision delay in stroke. So our plan is to identify patients at high risk of stroke out of pharmacy data, and then contact those patients with an intervention that, again, will be co-designed with the pharmacy partners. And we'll test the feasibility of the intervention in early 2017. And right now, we think we've identified the test pharmacy in Placentia, California. We're looking for, similar to what Dr. Klingman mentioned, we're looking for a pharmacy that can be an early adopter, that has the pharmacist that can engage with us in the design process. So that's our, we call it the stroke drills intervention and the faster study. So that's the first piece of work that has grown. It's really grown since those three fellows came to present this model in 2013, and we're really excited about it. So, so I think I'll stop there for a second and take any questions you have about what we're doing. Yeah.
I just have a basic question that's overwhelming to even think about. Are you looking at the ER culture? If these folks don't happen to land in one of these centers that really focuses on stroke, and I have worked ERs, small and large, and they come in and it's, oh, she thinks she's having a stroke, so she gets put in a chair, you know, and then meanwhile the person who thinks they're having a stroke comes in, you know, with an ambulance, and they get immediate attention. But what can be done, is anybody thinking about the ER culture? You know, someone comes in and says, I think I'm having a stroke, or my arm is weak, or whatever, that it doesn't get brushed aside, that we really cue in on those minimal symptoms that can lead to something bigger if it's not picked up. I mean, it's a culture all of its own, and I've been there.
Well, I think that's a really interesting question, and I think, well, so first of all, there are a few ER physicians that I've already met, and I think many more, that are very interested in addressing these issues, the culture issues and the faster stroke treatment issues, both from the point of view of working within the EMS system and working within the ED. So I do believe that we've got some really great champions out there to do this work. The other thing that it raises for me is, you know, I did spend, when I was at the Gordon and Betty Moore Foundation, I spent about 3 years working on transitions of care and on this model of transition, Eric Coleman's model. And it was interesting, Eric Coleman, he decided he wasn't going to try to fix anyone's culture. He was going to actually teach the patients to say the right words to get the treatment that they needed from their physician. So I don't think that can solve the ED culture problem, but it could be, you know, it could be one thing that we put into our intervention, because we are going to be looking at patients at high risk of stroke. Maybe part of that intervention could be, you know, what are the words that you say, you know, when you talk to when you call 911? What are the words that you say when you speak to your physician? And what words will really trigger the kind of fast response that we want. So, but it is kind of overwhelming.
Yeah, and the big thing is we key in on dialing 911. When I did my study with migrant laborers down in the middle of the valley, there was no 911. Their closest hospital was in Bakersfield. We were 2 hours away. And I asked them, what do you do if somebody has a heart attack? And they said, we put them in the station wagon and we head for Bakersfield. 2 hours away. So you can't assume, we can't always use our urban way of living and say, oh, dial 911.
Yeah, I think that's a really important point.
And those are things that often get left off because it's such a momentous thing to tackle, and I understand that, but just to get people thinking that far out.
I think that's a really important point, and you know, we'll talk about it in the next section, but one of the ways that we'd like to conquer this problem is look at it regionally. So basically take the local EMS agency groups that are sort of, I think there's 32 around the state, and actually try to adopt the practices in a way that makes sense for what the EMS services look like in each region.
Dr. Erdl has a question here for Christine.
So it's really more of a comment. I think that it has to do with, say, mild stroke symptoms. Everything is a red alert, all of it. Mild weakness, mild slur of speech, mild, all of it should go to the red alert level until proven otherwise. And I think that that's something that doesn't translate well to patients, families, or to some ED or to some physician. Yeah, so, an example, not exactly the same, but I was called one morning as an administrator by my brother-in-law, who said that your sister woke up today and has double vision. I said, really? Put her on. And I very clearly described it. I said, put Dan back on. I said, Dan, drop everything, hang up the phone, and drive her to the emergency room right now.
As
Because
opposed to 911.
it would have taken this long for where they live. It was faster for them to do it that way. So now, so is it a detached retina? Is it a brain tumor? Is it a stroke? What is it? It's all bad until proven otherwise. And so it turned out to be primary presentation of something else. So that it's red alert until proven otherwise. I think that that's a mindset that people need to go to a stroke. If you are thinking that this might have a 5% or 10% potential of being a stroke, go to red alert and prove it otherwise. And people don't do that.
People have no idea to do that.
Right, and I think that that's part of the lack of training. You have people, they can pass the test. When they see it on the street, they see it in real life. The whistles don't go off, and they don't go to red alert, and they say, we're calling EMS, because that's exactly what they should do.
There was
So,
a really interesting study done in Michigan where they actually, instead of just asking people, do you know this, they had a big campaign, mass media campaign. And then instead of asking people, do you know the symptoms of stroke, they gave them scenarios. And for the very clear-cut scenario, lots of people either said, I would drive the person to the ER, or I would call 911. Of course, we wanted the answer to be call 911. More people answered call 911. But for the other two scenarios, which were less clear-cut, the attribution to stroke and calling 911 went way down. And a lot of people either said, I'll call my doctor, or I'll drive the patient to the ED. And it was really interesting to see that, even though people are trained in the symptoms, that attribution around mild stroke and that ambiguity and sort of some of the emotional coping things really get in the way of the
they really
behavior.
get in the way, and again, patients, families, everybody should go to red alert. And that's what's lacking, I think, for really getting people on board with this.
So before we take Liz's question, I just want to say that we have a little bit of cognitive dissonance here, where you're saying because it was faster for them to drive directly.
I would advise that as a norm.
Oh, okay, so the norm should be
Call
dial
EMS.
911, because
Call 911.
what we heard in this room before you joined our group is that every one of our hospitals in the Sacramento region, and every community is different, does not have a neurologist on staff at all times. So what the key piece is for 911 is they'll get you to a place where there is appropriate staffing or do their best to do so. I think we'll take Liz and then Juanita.
So, hi, Liz Thompson in Chronic Care Coalition. Boy, this really touches my heart in multiple ways.
Oh, good.
So, one, I'm aligned with what you're saying. Two, I don't see stakeholders representing nonprofit organizations at your table, and we would love to work with you.
Oh, that's great.
Huge, huge issue for us. Second, I experienced it personally with my husband. Now, I'm in this room. I have been working with Right Care almost since it started. I'm a pretty well-educated consumer. I'm watching my husband, what I think he's having